SE203 Exercise Physiology. Acute respiratory responses to exercise. Respiratory system. Gas exchange involves the upper respiratory tract, the nose, mouth, and throat, and the lower respiratory tract, the larynx, trachea, bronchi, lungs, and diaphragm. Remove CO2 supply and supply oxygen. Regulate water in the body through evaporation and perspiration. Breathing at rest, intercostals pull up when they contract, the diaphragm moves down when it contracts. The ribcage expands. Decrease pressure in thoracic cavity. Air flows in easy, so it allows it to fill the space. Tidal volume interacts with breathing frequency to regulate oxygen, carbon dioxide, and pH. The tidal volume of about 500 milliliters per breath, breathing frequency of about 12 breaths per minute, minimum VE of 6 liters per minute, VE or ventilation, and CO2 drives respiratory stimulus. Neural and mechanical and humoral sensors like dive reflexes and hyperventilation. The mammalian dive reflex is a preservation or survival reflex mechanism to minimize use of oxygen triggered by cold water and wet environments around the nose and eyes and forehead while breath holding. Intercostal muscles relax, they move down, the diaphragm relaxes, moving up, the ribcage condenses, increasing pressure in the thoracic cavity, air is pushed out forcefully from the lungs. During exercise, ventilation increases, tidal volume increases from 12 to about 70 breaths, from 500 milliliters to 2.5 liters, and ventilation goes to about 175 liters per minute. Hypercapnic phase of functional hyperventilation increases ventilation but reduces TV. Light and moderate exercises, minimum ventilation matches oxygen uptake and CO2 and pH balance, a steady state in minimum ventilation, or min ventilation, is achieved over time. Heavy exercise, pH decreases due to hydrogen and phosphate and lactate accumulation. Carbon dioxide increases due to energy system shift. Increase in partial pressure of only 1.7 milliliters per hydrogen is enough to trigger chemoreceptors. Steady state of ventilation is not achieved. VE, or ventilation, immediate increase to 2 to 3-fold increase in min-ven. VE continues exponential rise to 20 to 30 seconds in minus ventilation. Steady state balance in oxygen, CO2, and pH. Pressure changes in arteries. The body cannot see change in arterial partial pressure of oxygen due to the speed of oxygen moving in the body. Skeletal muscles, partial pressure drops and carbon dioxide partial pressure increases. The change allows the exchange of gases to increase in speed, as there is a greater gradient for diffusion affecting AVO2 difference. At rest about 5 milliliters, and in exercise about 18 milliliters of AVO2 difference. In exercise, AVO2 is influenced by increased blood flow, increased oxygen circulation, diffusion gradient between oxygen between the artery and capillary, and increased partial pressure of CO2. Myoglobin store in muscle benefits from low partial pressure. Oxygen wants to bind to myoglobin, so it makes transfer faster for skeletal muscle. The Bohr effect of hemoglobin's binding is inversely related to pH and CO2 concentrations, so if one goes up, the other goes down. The Haldane effect, empty hemoglobin attracts waste products from tissue, more unloading of waste products. Oxygen kinetics. Using a dynamic profile of VO2 response to exercise, of different intensities. 3 phases to describe. 1. Rate of aerobic and anaerobic energy synthesis. 2. Mixture and amount of substrate utilized. 3. Tolerable duration of the exercise. And the last phase is just the time to reach a steady state. VO2, oxygen before exercise, is the baseline. Phase 1, cardiodynamic phase, delay of 10 to 20 seconds, as pulmonary VO2 does reflect muscle oxygen uptake, not heart rate. More effect to venous return and right ventricular output. Phase 2, fundamental primary or fast component. Pulmonary VO2 reflects time constant of muscles VO2 plus minus 10%. Phase 3, slow component, not needed in light exercise. Slow continued increase in VO2 due to muscle fiber recruitment. Maximum accumulated oxygen deficit, or MAOD, and exercise post-exercise oxygen consumption, or EPOC. MAOD, VO2 max at MAV, is 65 milliliters per kilogram per minute. Theoretical VO2 consumption run at 115% of MAV, or 75 milliliters per kilogram per minute. For 150 seconds would be 75 times 2.5, 188 milliliters per kilogram per minute, estimated in triangle by deficit of oxygen buildup. Measured VO2 consumption, 125 milliliters per kilogram per minute. So the actual measure from the mask or whatever the data is being collected from. MAOD difference between theory and practice, about 188 to 125, about a 63 milliliters per kilogram per minute. EPOC is exercise duration dependent, as exercise post-exercise oxygen consumption. Yes. MAOD, more exponential and intensity dependent. Indirect calorimetry or spirometry, finding RER predicts fuel utilization. Caloric equivalent for RER to predict calories per liter of oxygen. Overall, secondary criteria like blood, lactate, and heart rate and such do not assess VO2 max as good as direct measures. Protocol matters and can show relevant difference best to tailor to the athlete or specific piece of data you want.